Hi everyone, Dr. Michael Miyazaki here again, and we're going to switch it up a little bit today. We've been talking a lot about materials and endo and aesthetics, so I'm going to shoot back over to occlusion because occlusion, I don't know, in our practice is kind of taken off. We've been seeing a lot of patients for TMD and other related issues like airway issues. So I just wanted to kind of go back and share some of my insights that I have on occlusion. Now, real quick, my background over the last almost 4 decades is I knew nothing about occlusion, was just kind of a habitual bite type of guy. And then I got into romancing the mandible and finding the correct jaw joint position, trying to rebuild to that. And today I'm a little bit more free. I look more for a physiologic position, and that's what I want to try to explain to you today, because going back 20 years ago when I first started doing this, it was kind of counter to what I thought was the way to look at occlusion. And when you fast forward and see which way Airway is going, is Airway is becoming a big concern amongst physicians and dentists, oral health care providers. And if we take the jaw and we push it back, that's not opening up the airway. So what we're finding today, at least I'm finding, that if I allow the jaw to go to a physiologic position, the patients are much more comfortable, they have better health, better airways, and I just find that it does a lot of good. So if it's a little bit counter to the way that you approach occlusion, or it's very different, because a lot of us just kind of do the blue dots, try to get the habitual bite okay, and that works for you, great. If you're manipulating the mandible or using deprogrammers and that's working for you, great. I don't get over dogmatic about the philosophy, but what I like to do is just share ideas. And so that's what this is all about. If you are having patients that are coming in that are going through things like TMD, then this might help you a little bit. So here's a patient, just going to start off with this, where when you look at this patient at rest, you can see that the bite looks pretty normal. But when you look inside the mouth, what we've got is 4 bi-extractions. So bicuspid's been extracted, bicuspid's been extracted, bicuspid, and bicuspid. So what that means is that for this patient, they had to pull everything together. If you look at the roof of the mouth, we've got a palatal-tori, which not only invades the tongue space, but that could be because of the lack of arch space. Now we have a V-shaped palate, which then means that the patient's sinuses have less volume. The tongue that you see down here compared to the arch width is the tongue is very wide compared to the very narrow arch, because they had to constrict the width of the arch as they pulled everything together. Another thing that you look at, because this patient came in complaining of TMD, jaw pain, and when you look at what's going on with the bite, look at the maxillary midline here, which lines up with the frenum. So her maxillary midline with the face was pretty much right on. But when you look at the mandibular midline, her midline shifted over to the right-hand side. So something's throwing things off. And when she is asked to open a little bit, basically disengage the bite, look at her midline goes even further over to the side. So we know we've got things that are off. And could it be because the bi-extractions and the shifting? It could be, but regardless, what's that doing to the jaw joints? So that's why I look at this. If I ask the patient, hey, do you have any place where you feel comfortable when you place your jaw? This patient will say, right there. So you can see she's bringing her jaw forward, having to open up the vertical a little bit, and she has what we call bicuspid drop-off, where the cuspid height is much higher than the bicuspids and molars. And why is that? Probably because her tongue is so wide, as it rests on the occlusal surfaces, it kind of intrudes those lower posterior teeth, and as it intrudes those teeth, she's going to get an even deeper bite. So as you look at this, these are the very common patients that you'll see, and they will complain of TMD pain. So think about this, kind of lock the picture in your mind, and when you go back to your practice and you see patients with those 4 bi-extractions, ask them, hey, do they have clicking and popping in the jaw joints? Do they have tender muscles of mastication? Do they have airway issues? Kind of start to dig a little bit deeper, and you might identify some things that are going on in the patient's mouth, which will be very interesting to you and to them. So again, this is where I ask the patient, hey, position your jaw where it feels comfortable. So she's sliding her jaw forward, not pulling it back, but she's feeling that it feels better when she slides her jaw forward. So what we do in our practice is we actually relax the muscles. So I use what's called a J5 myomotor. It's an ultra low frequency tensing unit. We put the pads on both sides of the face, sometimes even on the cervical areas if the patient has a lot of neck discomfort, and we tense them for 45 minutes. We relax the muscles to figure out where they want to go. If this is a TMD patient, TMJ patient, they have a lot of tension built up here. So I don't want to just shoot a bite. And that's why a lot of you will use deprogrammers, because you want to give the patient time to deprogram the muscles. Well, I don't have the time to fabricate a deprogrammer or get a deprogrammer, have them wear it for a week or two, and then capture the bite. I just ask them, hey, would you mind sitting here for 45 minutes? We're going to use a tangent to relax the muscles, and once we get the muscles relaxed, I am going to take a bite registration. And so these are the muscles that are innervated by the muscles that we are activating with this TENS unit, cranial nerve 5, which are basically the muscle of mastication, cranial nerve 7, which are the facial muscles of facial expression, and cranial nerve 11 muscles, which are supportive to the cervical posture and airway. So that's what we're looking at when we're doing this. And what happens is when we have the patient hooked up to the TENS, every second and a half we get a gentle pulse that elevates the mandible just a little bit, increases the circulations in those very tight muscles, lets more blood to get in there, helps relax the muscles. And as we relax the muscles, we get a better joint position. So we go to a physiologic position that is not constricted. We don't restrain or manipulate the mandible. We let the mandible go to where it wants to go. I squirt some bite registration material between the teeth and I take my bite. From that bite, I have a myriad of different orthotics that I have made. Now, different than a night guard. A night guard is an appliance that I make that protects the teeth that the patient's clenching or grinding. But an orthotic is actually trying to reposition the mandible to the maxilla, which is kind of the fixed unit, and then trying to get the joints in a better position, more physiologic position, and trying to allow the muscles to relax. So that's what we do here. And then I have, in this case, a lower orthotic that's fabricated, and we adjust that to get her comfortable. Now, in this patient's case, the patient closes down. I will many times have the anterior kind of open bite there without trying to lock their anterior teeth in, but I'll have good stable posterior occlusion. And after wearing this for a week, the patient said, oh, it felt so much better. And one of the things that I've learned is by changing the bite, you can oftentimes make TMD feel better right away. It is a long-term comfort of the patient that I judge the use of the orthotic by more critically. And this patient, after months of wearing this, says, I feel better when wearing this than when it's out of my mouth. And so we know now that that's a more physiologic position. So this position was more therapeutic. It allowed the patient to heal up and to relax. And as the patient heals and relaxes and the inflammation in the jaw joint area goes down, we can adjust this acrylic accordingly. And then it becomes something that maintains stability for the patient. Phase 1, we can show the patient we can make them better. And now phase 2 would be something where we can move the teeth to improve the occlusion so they don't have to wear an acrylic orthotic for the rest of their life. Just want to show you how, because in this case, in the first case, what we did is we kind of just relaxed the muscles, took a bite, and used an orthotic. This is how we incorporate some of our diagnostic equipment, because you can tell patients, hey, you've got headaches and I can get your muscles in a better position to relax the muscles and to help the jaw joints. But sometimes it's hard for the patients to believe or understand. They've been to other dentists and the dentists have said, well, I can make you a night guard, or I need to do surgery or give you muscle relaxants or whatever. And so it confuses the patient. So I just want to show you how, again, we handle it in our practice. When the patient comes in, that form I showed you before in the other programs, it's a smile evaluation sheet. Well, this is a pain evaluation sheet where I'm asking patients, how does your joints feel? Do you have pain in muscles? Do you have pain in the jaw joints? Do you have ringing of the ears? Do you have pain in the neck? What's going on? So I'm asking them all these questions. This patient had been asymptomatic, had gotten into Invisalign treatment, and that started 6 months ago, and now she's having a lot of joint pain, pain in the back of the head, the occiput area of the head that goes from the back of the head to the front, and the temple area and the front of the forehead area. The joints have begun to click and pop, and that's really what has concerned her. So when she came in, I asked her, do you have any history of recent trauma or even past trauma? She said no. I checked the range of motion. She had good range of motion, opening at least 40 millimeters and going 10 millimeters right and left, and about 8 in protrusive. So her history was she started the Invisalign treatment. All these symptoms developed. She went back to the doctor providing her with the Invisalign treatment, and the doctor just gave her muscle relaxants. Well, the muscle relaxants just kind of make her loopy. She can't function, so she can't do that. So she goes back to the dentist. He refers her to a TMD specialist who's also a surgeon, and the recommendation is, well, maybe surgery or maybe Botox. In my opinion, no one's done anything wrong at this point, but if we do something like Botox, we're just masking the symptoms, but we're not really treating the cause. And so what we want to do is we wanted to help this patient find the cause of the headaches and the clicking and popping of the jaw joints. So what I'm going to do at this point is, after we go through the history, I could hear the clicking, the popping of the jaw joints. I could palpate the muscles, and yes, they were sore. But again, that's all very subjective. So what I want to do is I want to get some objective information so I can share it with the patient, show what's going on, and how we can then improve it, or how we can let the situation improve itself. So we put pads, and these are, I tell the patients, you've seen the medical shows where they put the pads on the patient's chest and they measure the EKG. Well, that's measuring the electrical activity of the heart. And so what I'm going to do is I'm going to put pads on some of the muscles that are involved with your bite to see what the muscles are doing. So we put pads on the temporalis muscles and the masseters. And what I do is, at this point, I wasn't measuring the jaw position. I wasn't using the tens. I just want to see what the muscles are doing as she's biting down to figure out why is she getting these headaches. Now, what we try to do is we try to find a position where the muscles are relaxed. And that just means we don't have a lot of muscle activity. Because just like if I go out and I lift weights, I'm going to have a lot of muscle activity. And if I was measuring the electrical activity in my muscles, you'd see a lot of it going on because we're activating the muscles. But the more I do that, then I know that tomorrow I'm going to be sore. What I would like to do is go on a vacation and not use my muscles, allow them to relax, to recover, recuperate, and take all that pain away. So we're kind of doing this with this patient. So with those pads on, what I'm doing is I'm looking at what the muscle activity is. And so so these screens go from 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15's over here. So it's a 15-second scan. So for about 7 seconds, I tell the patient, hey, put your trays in, your Invisalign trays, but keep the teeth apart. Just keep a little bit of space between the teeth. So that way the mandible's kind of going to wherever its habitual rest position is. So the trays are in her mouth, and we don't have the retractors in. I just did that for the photos. But now just relax your jaw. And what you can see is there's very little muscle activity. These numbers, this is in the boxes, is the average reading after almost 7 seconds. So 1.9, 0.9, 1.1. So we're right about a reading of 1. These are microvolts of muscle activity. And 2 or less is usually really good. So the fact that we're at 1, that looks really good. And I'll explain to you why it could be a 1 that could be bad, but that looks good so far. So now with the trays in, I say, okay, gently close down with your Invisalign trays on. Just gently bring the teeth together. Don't clench down because, of course, that's going to create a lot of muscle activity, but just gently bring the teeth together. I want to see what's going on. So here we go. We're going to have her just gently close down on the trays, which you see in the photo there. But again, I didn't have the retractors in there when we did this because that could activate muscle activity. But what you'll see is here's the left anterior temporalis, and we went from 1 to 12.7. This is the right anterior temporalis. We went from 0.9 to 13.6. Now the left masseter and the right masseter stayed about the same. So what's going on with the temporalis muscles? Well, remember the temporalis muscles are like a fan. There's some vertical fibers, diagonal fibers, and some that run kind of horizontally. Those are position muscles. So as the patient closes down the trays, those position muscles are ahead and position the mandible to get them into occlusion with the trays. And that's why you see all this activity going on. Well, how do I know she's not just clenching to activate these temporalis muscles? Because look at the masseters. The masseters did not change significantly. So what this shows me is that when she's closing down the trays, her position muscles, the anterior temporalis muscles, are working to figure out where to position the mandible so that the trays can come together. And that is like lifting a heavy weight. And imagine doing that all day long. So as she's doing that, the muscles are getting tired, and that's why she's getting these headaches. And with these graphs, you can see that the one here, that's where the teeth are at rest. And when she goes into light CO, you can see the difference. And a 1,400% difference on the right side, and almost a 1,200% difference on the left-hand side. And the masseters barely changed. They did change, but you'd expect that because we were having her close down gently, but nowhere like the 1,400% that you see over here. So right away, it makes sense to the patient. Okay, imagine these muscles are working that hard, and the patient might say, but I spend most of my day with my teeth apart. Well, imagine swallowing 2,000 or 3,000 times a day. When you do that, you're positioning the jaws, because when you swallow, the teeth come together. And it's just like lifting a 5-pound weight 2,000 times. Well, I can do it 10 times. It's not going to even bother me. But if I had to do it 1,000 times, now that muscle's going to get sore. So this graphic and doing objective measurements helps me explain to the patients what's going on. Now she says, well, what's going on with the clicking and popping in my jaw joint? So what we do is, you'll see in this photo over here, is we're going to put a magnet down in the anterior portion of the mandible, and this headset right there just tracks where that magnet goes and how fast it moves. Well, here we're just going to measure its position. So what I want you to see is, in this diagram that's magnified here, this is a sagittal side view of the head. And imagine that this line indicates where that magnet over here is moving in space. So as the patient opens and closes, that magnet's going to go up and down when we look at that magnet from a side view, right? Remember, a side view. So what we're able to do is, we have the patient, I'm not having her tens at this point, but I'm having her just move her jaw up and down, but not touching the teeth. So she's just taking her jaw, going up and down like this. And what I'm doing is I'm tracing the trajectory of the jaw without the teeth being involved. Now I say, okay, bite down. So now her teeth are coming together and her mandible is going backwards. Remember, that is activating the anterior temporalis muscles, because we have to pull the mandible back. And the computer is showing me that we're having to pull the mandible back 2.2 millimeters in a horizontal plane to get closure to CO. Now, from the frontal view, so this is tracking the magnet going up and down from a frontal view. Basically, it's just showing that the magnet's going up and down along this line. Then she taps up and down, and it's all pretty much along the same line. So where we're seeing the largest discrepancy is from an anterior position. So let me explain this to you one more time. So the magnet from a sagittal side view, looking at her head, is going up along this trajectory. If the teeth were not coming into play, her mandible would bite down to a CO position right here. But where her CO is back here, she's having to retrude her mandible 2.2 millimeters. That is activating the anterior temporalis muscles, because they're having to pull the mandible back. So why is she getting the clicking and popping? Because as she's closing down, her mandible is going back 2 millimeters. We're popping off the disc, and that's what's giving us the click and the pop. Because I believe the condylar head is being displaced posteriorly while the disc is going more anteriorly. So what's really interesting is, when you're able to explain this to the patient, it takes that fear away, because they want to know, why are my jaws clicking and popping, and why am I all of a sudden getting these intense headaches? And many times if I tell the patient, well, that's the little cartilaginous disc that's clicking as you open and close, they don't really understand, well, is my jaw going backwards? Well, when you can show them with these graphics and we measure the muscle activity objectively, now it begins to make sense. So here what we're able to do is we're able to show her the EMGs when she's going to her habitual CO in the trays, high muscle activity. And then when she opens up and goes to her habitual rest position, the muscle activity drops way down. And when she's able to open and not close down the trays, the mandible is able to come forward, and the muscle activity can then drop. When she reverses that and brings her teeth together with the trays on, now the muscle activity climbs 1,400%. So What I want you to do is keep an open mind. Occlusion is a really cool thing. It's foundational to everything we do, whether it be aesthetics or everyday dentistry. But start to look at your patients when you go back to your office and you're looking at them. What does the arch form look like? What's the spacing look like? How big is the tongue compared to that arch? And think about what the condyle and the muscles are doing when the patient bites down. All right? So I hope you like this. If you like this type of information, hit subscribe. If you liked it, hit the like button. We're creating a community of like-minded clinicians that are trying to do the very best for their patients. And it's a lot more fun when we stick together and provide this type of treatment together. So I hope you liked today's program. I look forward to seeing you during the next program. Thanks very much.